London, and today our session is all about type 2 diabetes. So we're going to be using some single best answer questions to take a bit of a tour through the topic of type 2 diabetes. It's obviously an enormous topic to try and cover in an hour, so we'll kind of try and hit the highlights of things that might come up in your exams and that might be useful for clinical practice. And if you have any questions, feel free to put them in the Q&A box and I'll answer them at the end if that's all right. Okay, so why are we talking to you about type 2 diabetes today? Well, you've probably figured out already from your clinical placements that it's a hugely prevalent condition, affecting 3.5 million people in the UK so far, but expected to rise to 5 million within the next 5 years alone. And it's a condition that's associated with significant morbidity and mortality, with average life expectancy for people with type 2 diabetes reduced by 10 years on average. It also accounts for a significant proportion of NHS expenditure, up to 10%, and yet it's largely preventable. And it's certainly a condition that you'll come across in just about any branch of medicine that you could go into. So, having set the scene a bit, we'll start with our first question of the session. So we'll give you a minute to read through the slide, and then there should be a poll that pops up for you to select which one you think is the correct answer. I need to move this out of the way a bit. Okay, brilliant. So 96% of you have selected the correct answer there. So beta cells, which are found in the islets of Langerhans, are responsible for insulin secretion, and it's dysfunction of those beta cells that is part of the underlying cause of type 2 diabetes. I suppose the fact we're talking about, this is a whole talk about type 2 diabetes, was a bit of a giveaway to the diagnosis there. Just to run through the other options quickly. So your parietal cells are found in the stomach and they secrete hydrochloric acid and intrinsic factor. Delta cells are found in the pancreas and they secrete somatostatin, which suppresses insulin and glucagon release. Epsilon cells are also found in the pancreas and they produce ghrelin, which is the hormone that induces hunger. And pancreatic polypeptide cells, or gamma cells, do what they say on the tin. They produce pancreatic polypeptide, and that's involved in self-regulating the endocrine and exocrine pancreatic functions. Okay, so if we start by thinking about the normal physiology, so your beta cells would normally produce insulin secretion in response to raised blood sugar levels or blood glucose levels. And normally that insulin in the bloodstream binds to insulin receptors on the cell membranes of adipose tissues and muscle cells. And this triggers the glucose transporter to move from inside the cell to the cell membrane, enabling glucose to move from the blood vessels into the cell, where it's either stored as glycogen or broken down in glycolysis to produce ATP. However, in type 2 diabetes, we have increased insulin resistance in the tissue. And this means that although insulin is being released as normal by the beta cells, it doesn't trigger that movement of the glucose transporter to the cell membrane. And so glucose can't move into the cells. Now, initially, there's hyperplasia and hypertrophy of the beta cells as they try to compensate and increase insulin production to overcome this insulin resistance. But it's not a sustainable response. And eventually those beta cells, they hypertrophy, there's hypoplasia, and there's apoptosis. And so as less insulin is produced to overcome the insulin resistance, blood glucose levels continue to rise, and that triggers the symptoms of type 2 diabetes. And it's just a quick note to say that there's also thought to be a role for alpha cells in the pathophysiology of type 2 diabetes. So some dysfunction of the alpha cells is thought to cause raised glucagon levels, which also contributes to raised blood glucose. But the sort of pathophysiology for that isn't quite as well understood at the moment. So moving on to think about the symptoms of type 2 diabetes. Of course, some patients are completely asymptomatic and their type 2 diabetes is picked up through screening programs. For other patients, you can get the sort of classic symptoms that we often think of with type 1 diabetes, so polydipsia, increased thirst, polyphagia, increased hunger, polyuria, increased urination, and weight loss. And this tends to happen sort of subacutely, so over a period of weeks to months. There are also certain signs you can see. So acanthosis nigricans is a sort of thickening and darkening of skin in sort of the body folds, so around the neck, the armpits, and the groin classically. And then some patients will present with sort of signs and symptoms related to the complications of diabetes. So things like blurred vision, recurrent infections, paresthesia, erectile dysfunction, slow healing wounds, and so on. So what are the major risk factors for type 2 diabetes? Well, the biggest one is obesity, accounting for 80 to 85% of the overall risk. And it's particularly central obesity that increases the risk. So measuring a patient's waist circumference gives you a better idea of their risk for contracting type 2 diabetes than BMI alone. Of course, obesity is associated with a sedentary lifestyle and a poor diet that's low in fibre, high in salts, fats, sugars, and in sort of like white breads, pastas, and other carbohydrates. Aside from obesity, family history is a major risk factor. So patients with a first-degree relative with type 2 diabetes are between 2 and 6 times more likely to develop diabetes themselves. And patients from an Asian or Afro-Caribbean background also have an increased risk. Women with polycystic ovarian syndrome are known to have impaired glucose regulation, and women who develop gestational diabetes have a 7-fold increased risk of developing type 2 diabetes later in life. And then some medications are also associated with an increased risk, so corticosteroids, for example. Okay, so moving on to question 2. Okay, so slightly broader spread of answers for this question, but the majority of people have gone for C, fasting blood glucose of 8.6. So this question is testing your knowledge of the thresholds for the diagnosis of type 2 diabetes, and the correct answer is C, fasting blood glucose of 8.6. Just before we go on to talk through all the different thresholds, you perhaps didn't think about HIV, particularly because this is a type 2 diabetes talk, but it is just worth pointing out that any patient presenting with symptoms of recurrent infections or hard to treat infections, the possibility of undiagnosed HIV should be considered. In this question, we're looking for the most likely diagnosis, and the patient doesn't have any particular risk factors for HIV or other examination findings consistent with HIV, which is why that's not the most likely diagnosis, whereas he does have risk factors for type 2 diabetes, the hypertension and obesity, and another symptom of diabetes, which is the polyuria. Okay, so when we are thinking about diagnosing patients with type 2 diabetes, if the patient is asymptomatic, you need at least 2 separate readings that are both over the threshold for diagnosis. If the patient's symptomatic, then you can be more confident of making the diagnosis with just the one reading. And in clinical practice, especially in GP land, you've probably all seen HbA1c being used quite frequently. So a HbA1c reading of 48 or above is considered to be diagnostic of type 2 diabetes. So HbA1c is a measure of the glycation of hemoglobin, and it's like an average reading for blood glucose levels over the past 3 months. There are some situations when using HbA1c is not appropriate, which I've included in the red box there. It's not an exhaustive list, but it's a few examples for you. So particularly when the lifespan of an erythrocyte is less than 120 days, then your HbA1c is not going to be accurate. An alternative to HbA1c is fasting glucose, which again is used quite commonly in practice. And so a reading of 7 millimoles per litre or above is considered diagnostic of type 2 diabetes for fasting glucose, which is why option C was the correct answer in this case study. Less commonly in practice, you might see random blood glucose or 2-hour oral glucose tolerance tests being used, and the cutoff for those is 11.1 or above. The 2-hour oral glucose tolerance test is used more commonly for the diagnosis of gestational diabetes, but there's a lower threshold for the diagnosis of gestational diabetes. It's not 11.1, just to point that out to you. Okay, question 3. Okay, brilliant. So again, the vast majority of you have gone for the correct answer here, which is metformin. So this question is looking at the most appropriate first-line oral glucose lowering therapy to initiate. the case study mentions that the patient was diagnosed with type 2 diabetes 2 years ago and completed a patient education program then, so he's likely already had advice about lifestyle changes that he can make, and he's not got any particular past medical history of note that might be a contraindication to starting metformin. So just a quick note to say that obviously discussing lifestyle changes with patients with type 2 diabetes is really important, especially when they're newly diagnosed, because some patients can keep their diabetes under control just with these lifestyle changes. So what should you be advising them? Well, firstly, they need a diet that's high in fibre, low in fat, low in salt, and where they have lots of low GI carbohydrates rather than high GI carbohydrates. So using whole wheat breads and pastas and rice and so on. You should be encouraging patients to get plenty of exercise, aiming for at least 150 minutes of moderate intensity exercise per week. And that's really important because exercise alone will improve insulin sensitivity and reduce the patient's cardiovascular risk, even if they're not able to lose weight doing the exercise. If the patient can achieve some weight loss, then a weight loss of between 5 to 10% of total body weight is itself associated with reduced cardiovascular risk and also with better glycemic control and delayed progression to the complications of diabetes. So definitely worth doing. And of course, it's a good opportunity to talk to patients about other cardiovascular risk factors like smoking cessation and moderate alcohol intake. But assuming we've talked to the patient already about all of those lifestyle things, the NICE guidelines for the initiation of oral glucose lowering medications are as follows. So you start with standard release metformin once the patient's HbA1c is at the diagnosis threshold for type 2 diabetes, so 48 or above. And you would start at the lower dose of metformin and gradually work your way up, aiming to keep the patient's HbA1c below 48. Assuming that you've titrated the metformin up to the maximum dose or the maximum dose that the patient can tolerate, if despite that their HbA1c gets up to 58 or above, then that's when you're going to start thinking about initiating a second oral glucose lowering medication. And which medication you add in to metformin is it's a bit of a prescriber's choice, really. It depends on the patient's clinical situation, so whether they have any other comorbidities or past medical history. That means that some of these medications might be contraindicated. It depends on factors like their age and their risk of developing like hypoglycaemia and so on. We'll talk about each of these in a little more detail in a minute. But your target once you start a patient on a second oral glucose lowering medication is to keep their HbA1c at 53 or below. And then assuming you've titrated this second medication up as high as you can go and their HbA1c is still persistently 58 or above, then you would add in a third agent. Again, and there's some variation in which ones you can choose there. For some patients, you might also think about moving them on to insulin at this point rather than adding in a third agent. So we could spend an hour just talking about all the oral glucose lowering medications, but to kind of have a quick run through of them. So metformin is your first line, and it works by increasing insulin sensitivity in the peripheral tissues. It's used first line because it doesn't cause weight gain and it doesn't cause hypoglycemia, obviously big benefits. It's generally quite well tolerated. The most common side effects are gastrointestinal, so things like diarrhea, flatulence, bloating, epigastric pain are quite common. It is contraindicated in patients with severe liver or kidney disease because it can cause lactic acidosis. So remembering that lactic acidosis is associated with metformin is quite a good thing to know for your exams, I imagine. So an alternative medication is a sulfonylurea. Gliclazide is quite commonly used here in the UK, and that works by stimulating insulin secretion from the pancreas. It is associated with weight gain generally for the sulfonylureas, but not for gliclazide specifically. But all of the sulfonylureas are associated with hypoglycemia. Pioglitazone is the only glitazone that's currently licensed for use in the UK. It works by reducing peripheral insulin resistance, and it is associated with weight gain, but not with hypoglycemia. It's also associated with an increased risk of heart failure bladder cancer, and of bone fractures. So it won't be appropriate to use for quite a number of patients, especially some of the more elderly patients. DPP-4 inhibitors like sitagliptin work by increasing insulin secretion. Sometimes they're associated with weight loss and they have no effect in terms of causing hypoglycemia. And SGLT2 inhibitors, an example would be dapagliflozin. These actually work on the kidneys, so they reduce glucose reabsorption and increase urinary glucose excretion, which in turn reduces blood glucose levels. They can often cause weight loss, so they can be quite useful in patients who are really struggling to manage their weight, and they're not associated with hypoglycemia. But because they create a very glucose-rich urine, patients have an increased risk of developing UTIs and genital candida with this medication. And then, of course, you have insulin, which you're giving to replace the endogenous insulin that isn't being produced in high enough volumes, and that is associated with both weight gain and with hypoglycemia. So if insulin is going to be started for a patient, it's going to be started by a specialist team. But it's worth knowing a little bit about it because it's something that you'll probably end up prescribing on the wards and so on. So normally you would start a patient on insulin if their insulin secretion by the beta cells in the pancreas has declined sufficiently. And that's often associated with new symptoms like increased lethargy or an increased HbA1c despite maximum medical treatment. So the normal physiology is that beta cells release insulin in 2 phases. The first phase is a sort of rapid response to increased blood glucose levels, and it lasts for about 10 minutes. And the second phase is a more sustained, slow release that peaks in sort of 2 to 3 hours. And when we replace insulin, we try and sort of replicate this pattern with what you might have heard of as a basal bolus regime. So you can use an intermittent or longer acting insulin that creates that sort of slow, sustained release, and then a more rapid, short acting insulin at meal times to respond to those rapid rises in blood glucose levels. So a couple of examples for you of the rapid and intermediate insulins. So rapid and short-acting insulins are the ones that you typically inject 15 to 30 minutes before eating. Their peak onset is within 1 to 3 hours, and examples would be Nova Rapid and Humalog. Intermediate and long-acting insulins are typically injected once or twice a day, and their peak action occurs about 4 to 12 hours after administration. And examples of those would be Levemir and Lantus. And of course, patients with type 2 diabetes will need to have regular annual monitoring. What does that involve? So it includes eye assessments to check for diabetic retinopathy, foot assessments to look for diabetic neuropathy and diabetic foot ulcers, weight, BMI and waist circumference and blood pressure measurements to check for cardiovascular risk profile, of course HbA1c to check for their glycemic control. Usinase and urinalysis and urine albumin creatinine ratio are used to check for diabetic nephropathy, and again lipid profile and calculation of the cardiovascular disease risk score, or Q risk, is used to monitor their general cardiovascular risk profile. And of course it's another opportunity to talk to patients about their diet, their exercise, smoking and alcohol intake. Great, so we'll move on to question 4. Okay, again, a bit more of a spread of answers here, but the majority of people have gone for E, administer 10 to 20 grams of a fast-acting carbohydrate. So hopefully you've recognised that the patient's suffering from hypoglycemia or the symptoms of hypoglycemia, and that's confirmed by her blood glucose of 3.1, which is significantly below the normal range. So this question's asking you, what's the most appropriate first step in managing hypoglycemia in a patient who is alert and conscious and able to swallow? And we can tell that because she's got a GCS of 15 out of 15. And in this situation, the correct answer is E, to administer 10 to 20 grams of a fast-acting carbohydrate. So what is 10 to 20 grams of a fast-acting carbohydrate? So that might be half a can of a fizzy drink, or 4 large jelly babies, or 1 to 2 tubes of Dextrogel, which is something that's available over the counter and on prescription. So you could administer the fast-acting carbohydrate, and then you would want to recheck the patient's BMs about 10 to 15 minutes later. If it's not got their BM back above that normal range of 4.0, then you could administer another dose of fast-acting carbohydrate and check again after 10 to 15 minutes. If a patient was unconscious or had an unsafe swallow and they were in the community setting, then you might administer a 1 milligram glucagon injection intramuscularly. So some patients who are prone to hypos will carry glucagon around with them. If you administer the glucagon and 10 to 15 minutes later it's not had the desired effect, then you probably need to be moving on to intravenous glucose replacement at that point. And it's not really used that often in hospital settings because it's usually just much easier to give an intravenous glucose replacement. Most patients will have a cannula in place already. So the other alternative, if the patient is unconscious, is to give the 100 mils of 10% glucose intravenously. And this should be given into a large vein with a large gauge cannula or needle because it's quite an irritating solution. And again, if there's no improvement in 10 to 15 minutes, you just repeat the dose again. The octreotide subcutaneously is quite a sort of specialist medication. It's generally used if you have an unconscious patient who's not really responding to repeated intravenous glucose replacement. It's often used if the patient's sort of taken an overdose of sulfonylureas, for example. But it tends to be something that's used in the intensive care unit or with an endocrinologist's advice. So it's not something you see commonly in practice. And then your 15 grams of long-acting carbohydrate is what you would give to a patient after they've recovered from the hypo. So once their symptoms are resolved and their BM is above 4 again, regardless of how you got it there, you'd want to give them a long-acting carbohydrate. So that might be a piece of toast or a sandwich, or if it's coming up to breakfast, lunch or dinner, you can just give them their normal meal. Okay, so just to quickly run through. So some of the symptoms you might expect to see in a patient with hypoglycemia, you've got all the autonomic symptoms, which includes things like sweating, trembling, palpitations, a feeling of hunger or a feeling of anxiety. You get some neurological symptoms that might be confusion, drowsiness, difficulty speaking, poor concentration, or if it's more severe, the patient might be unconscious or even in a coma. And then some non-specific features like nausea, fatigue, and headaches. So some of the causes or triggers for hypoglycemia include missing meals. Alcohol can be a trigger, as it was in this case study. Exercise. A diabetic mother who's breastfeeding is more at risk of episodes of hypoglycemia, and someone who has poor compliance with their insulin regime. And you're more likely to suffer from hypoglycemia after one of those triggering events if you're at the extremes of age, so very young or very old. If you've previously had hypoglycemia, hypoglycemic episodes whilst asleep can happen because you haven't been eating for a longer period of time, and also for patients with renal impairment. And then some patients who have very strict control of their diabetes are at risk of something called impaired hypoglycemia. So most patients would recognise the symptoms of hypoglycemia and think to check their BMs or just take some short-acting carbohydrate. But patients with very strict control of their diabetes may be used to running at a very low blood glucose level. So their body might not necessarily produce all of those symptoms of hypoglycemia. And so these patients are much more at risk of sort of lapsing into a coma without realizing that they're suffering from hypoglycemia. And just to summarize what we were talking about on the slide, so if the patient's able to swallow, you start with your fast-acting carbohydrates. If they're unconscious, mainly in the community environment, you might give them IM glucagon. Otherwise, you'd go for intravenous glucose replacement. You need to repeat their BMs about 10 to 15 minutes after you've given them whichever one you're going to give them. And you can repeat the administration if you need to. And then once they're fully recovered, you give a long-acting carbohydrate. Okay, moving on to question 5. Okay, so this one's testing your knowledge of the driving rules around hypoglycemia in type 2 diabetes. And again, there's a bit of a spread of answers. The majority of people have gone for C, and then A is the second most commonly chosen answer. So in this patient, we've got a lady who has had 2 episodes of hypoglycemia that have required hospital treatment within the last 6 months. But she's currently got a normal BM and wants to drive now. So the DVLA guidelines state that any patient who has had more than 1 episode of severe hypoglycemia within a 12-month period must stop driving immediately and contact the DVLA. And they define a severe episode of hypoglycemia as one that the patient couldn't manage on their own. So whether that needed hospital admission or someone else to administer glucagon to them, that would be classed as a severe episode of hypoglycemia. So that's why A is the correct option and all the other ones are incorrect, because you need to tell the patient to stop driving immediately. She can't drive home from the hospital. So driving advice in type 2 diabetes, there's potentially lots of intricacies that you could read about online. I don't think you need to know them all off the top of your head. It's just really to flag some of these situations to you where you might need to remember to go and look them up and then to inform the patient before you discharge them. So patients who have a standard license for a car or a motorbike, firstly, obviously can't have any significant visual impairment caused by their type 2 diabetes, but they need to contact the DVLA if they are started on insulin treatment that's going to last for over 3 months. That's just informing the DVLA. They don't necessarily need to stop driving, but they're likely to be put on a restricted license by the DVLA. And then if they have more than 1 severe hypo whilst awake, they need to stop driving immediately and inform the DVLA. And if they have just one severe hypo whilst at the wheel of a car, they have to stop driving immediately and inform the DVLA. And the likelihood is that their license will be revoked. They can reapply about 3 months later, I think, if they haven't had any further episodes of severe hypoglycemia. And the rules are a bit stricter if they have a license to drive a bus, a coach, or a lorry. So if they are treated with any oral medication or insulin, even if it's something like metformin that's not associated with hypoglycemia, they need to inform the DVLA. And if they have even one severe hypo whilst awake, whether they were at the wheel or not, they have to stop driving immediately and inform the DVLA. Okay, question 6. Okay, so again, a bit of a spread of answers, but the majority of people have gone for B. So this question is looking for your understanding of the thresholds for diagnosis of hyperosmolar hypoglycemic state and what you might expect to find in a patient suffering from HHS. So HHS is an important hypoglycemic crisis to be aware of because it is associated with a high mortality, and it is more commonly associated in patients with type 2 diabetes than diabetic ketoacidosis is. So HHS has a sort of classic triad of symptoms. So you've got significant hypoglycemia as the first, and usually you expect a blood glucose of 30 millimoles per litre or more, so really significantly elevated. The second feature is raised serum osmolality, which you've correctly identified as the right answer in this question. And so an osmolality of 320 or above is sort of what you would expect to find in HHS. And then the third part of the triad for HHS is a patient with severe volume depletion, but without any signs of ketoacidosis, or without significant ketoacidosis, I should say. So those findings of 3+ ketones on urinalysis, of a pH on the ABG of less than 7.3 and of a serum bicarbonate less than 15, you would expect to find that more in a DKA than a HHS. It wouldn't confirm a diagnosis of HHS. So B is the right answer there. So in HHS, you've got extreme or profound hypoglycemia, and that glucose acts as a solute in the intravascular space. So it draws water out of the body cells and into the intravascular space. And that means that the body cells become dehydrated, and the increased intravascular volume causes polyuria. And so you're losing even more fluids and causing even worse total body dehydration. And that dehydration also causes hyperviscosity of the blood. So you get an increased risk of MIs and strokes and VTEs associated with HHS as well. Now, HHS and DKA are sort of often discussed as separate entities, but really they're more like 2 points on a spectrum of metabolic disturbance. And around a third of patients who present to hospital with a hypoglycemic crisis will have a mixed picture of HHS and DKA, so it's not always very clear cut. So how do you sort of differentiate between them? Well, in type 1 diabetes, you typically have an absolute lack of insulin production. And that means that the body has to turn to lipolysis and the breakdown of fats, which then triggers the production of ketones and then leads to diabetic ketoacidosis, so the significantly raised ketones. In comparison, in type 2 diabetes, patients have usually retained some endogenous insulin production, and that means that the body doesn't have to resort to lipolysis and ketone production. So patients with type 2 diabetes in HHS can present with extremely high blood sugar levels without a significant accompanying rise in ketones. And in HHS, symptoms will often develop over a period of days, whereas in DKA, it's more like a period of hours. Having said that, some patients with type 2 diabetes who are insulin dependent may be more likely to develop DKA because they're sort of not producing insulin on their own anymore. So the most common precipitating causes for HHS are infections, as in the case study that we had just now, but other potential causes are intercurrent illnesses. That could be anything from a myocardial infarction to an acute abdomen. Some medication increases the risk of HHS, substance misuse, and having generally poor diabetic control would also increase the risk. And how do these patients present? Well, they generally appear very, very unwell. They're fatigued, they're lethargic, they might complain of nausea, vomiting, and also some of the sort of common symptoms of high glucose levels like polyuria and polydipsia. There's typically a neurological component, whether that's confusion and drowsiness, or a focal neurological symptom, or in more severe cases, seizures and even coma. As I mentioned, the hyperviscosity of the blood caused by dehydration increases the risk of MIs, strokes and VTEs. And from a cardiovascular point of view, the severe dehydration results in tachycardia and hypertension. So serum osmolality, just to say, you can send blood samples off to the labs to calculate serum osmolality, but they often take quite a long time to come back. So there is a calculation that's kind of used commonly in clinical practice to estimate serum osmolality, which I haven't written on the slide, apologies, but it's 2 times the sodium value plus their glucose plus their urea, gives you an idea of what their serum osmolality is. And that's quite important for initially figuring out, how severe the HHS is, and also for you to monitor their response to treatment moving forwards. Okay, so we'll go on to question 7. So the case study is essentially the same for this one, with a bit more information about some investigations. So I'll just move it on to the question. Okay, so again, a bit of a split in answers here. And it's maybe a bit of a tricky one because a lot of the answers are actually quite similar to each other, aren't they? So this question is assessing your knowledge of the management of HHS, and particularly the first step in the management of HHS. So the real key thing to remember with these patients is that they are severely dehydrated. A 60 kilogram patient would have a deficit of 6 to 13 litres of fluid on average. So really a lot of fluid replacement is needed. Typically what is recommended is to replace the fluid at a rate of 15 to 20 millilitres per kilo per hour in the first hour. So that equates to usually about 1 to 2 litres in the first hour, depending on the weight of the patient. Just starting to replace that water deficit on its own will have a significant impact on starting to reduce the hypoglycemia, to reduce the osmolality, and to correct serum sodium levels. But correcting too quickly runs the risk of cerebral edema. So I'm sure you will find in practice when you're on the wards that all trusts have local guidelines that kind of lay out for you what to prescribe and when. So the correct answer for this case study was 0.9% sodium chloride at a rate of 1,000 mils per hour. So the rate is determined by that calculation that I gave you before, 15 to 20 mils per kilo per hour. So quite aggressive fluid replacement in that first hour. And we'll move on actually to talk about potassium. So once you've replaced the fluid, the next thing you might start thinking about is a fixed rate insulin infusion. So typically you would start a relatively low dose, so 0.1 units per kilo per hour, fixed rate insulin infusion. And you go kind of low and slow because bringing the glucose down too quickly can cause a refractory hypoglycemia and also hypokalemia. So on that note, if the patient's potassium is less than 3.3, then you need to replace their potassium in their fluids before you start administering the insulin. For our patient, their potassium was over 4, so that wasn't so much of a concern. So apart from replacing the fluids, starting the fixed rate insulin, correcting the potassium as needed, obviously you're going to want to treat the underlying cause that's sort of prompted them or triggered them to go into HHS, whether that's infection or an MI or a stroke or so on. And then of course you want to prevent any of the complications, and we talked before about the risk of VTE, so making sure these patients are on preventative low molecular weight heparin is also important. And once the HHS is resolved and the patient's tolerating oral fluids, and it's important to get the patient drinking fluids as soon as possible and keeping an accurate fluid balance, then you would probably move on to subcutaneous insulin replacement. Great, so that's just a quick run through of the immediate management of HHS. So we'll move on to some of the sort of longer term considerations for diabetes. Okay, so again, a bit of a split between B and C mainly, but the majority of people have gone for B. So this question is thinking about the management of a patient with type 2 diabetes and newly diagnosed hypertension. So for patients with type 2 diabetes, their target blood pressure for home or ambulatory blood pressure recordings is 135/85, and their clinic target is 140/90. So this patient's presented us with 7 days worth of home blood pressure recordings that show she's got an average reading above that threshold, which means we don't really need to be bothering with ambulatory blood pressure monitors. So the NICE guidelines for the initiation of antihypertensives in patients with type 2 diabetes is that ACE inhibitors and angiotensin II receptor blockers should be your first line choice. So ramipril is the correct answer here. Interestingly, they say that Afro-Caribbean patients who have type 2 diabetes and then develop hypertension should be started on angiotensin II receptor blockers first line. And that's different to the guidelines for patients without type 2 diabetes. So an Afro-Caribbean patient without type 2 diabetes would typically be started on a calcium channel blocker. But if they have type 2 diabetes, then it's recommended they start on an angiotensin II receptor blocker. So a bit of a discrepancy in the guidelines there to flag up to you. Great, so that kind of brings us on to think about some of the macrovascular complications of type 2 diabetes. So it's worth mentioning that the duration and the degree of hypoglycemia is directly related to the risk of developing complications. So the longer a patient has had diabetes for and the worse their glycemic control, the more likely they are to develop the complications of diabetes. And the macrovascular complications include cardiovascular disease, so MIs, angina and heart failure, cerebrovascular disease, so strokes and TIAs, and peripheral vascular disease as well. And so it's really important that we manage all of their cardiovascular risk factors because CVD accounted for 52% of deaths for patients with type 2 diabetes. It's a really significant risk. So we've talked a little bit already about managing hypertension for patients with type 2 diabetes. And we've said before that we check their Q risk score during their annual assessments. So patients who have a Q risk score above 10% should be started on atorvastatin as a primary prevention. And just to say that a low-dose aspirin is not normally recommended to be started in patients with type 2 diabetes unless they've already had cardiovascular disease. Okay, final question. Okay, so again, quite a broad, fairly even split actually between all of the options on this question. So hopefully you've recognised that this patient is presenting with painful diabetic neuropathy in his feet. And the question is asking about the most appropriate first step in the management of this neuropathic pain. So NICE guidelines tell us that pain for diabetic neuropathy should be managed in the same way as we manage any other kind of neuropathic pain. And that means that your first line in choice to manage the pain will be duloxetine or pregabalin or gabapentin or amitriptyline, depending on the clinical presentation and situation of the patient. So ibuprofen isn't recommended particularly for neuropathic pain, so that wouldn't be the best choice. Tramadol is sometimes used as a sort of short course to help to manage pain in patients who've already been started on the first line treatment for neuropathic pain. So they've already been started on something like duloxetine, but they're waiting to be referred to the pain management clinic. But it wouldn't be the first choice that you would go for. Capsicum cream can be used for patients with neuropathic pain who would prefer to avoid oral tablets, but given that his pain is quite diffuse and spread over both feet, the cream's probably not going to cut it, and it would be better to start with an oral medication. And then referral to pain management clinic, that would be appropriate if the patient had really severe pain that was affecting his activities of daily living, which it doesn't really sound like he does from the case history. But also you would expect to be trying at least something in the community, so trying the first line management for neuropathic pain before you sent the patient to the pain management clinic, bearing in mind that there's likely to be a waiting list for the pain management clinic anyway. So that's why duloxetine is the right answer for that question. That brings us on to talk a little bit about diabetic neuropathy as a topic. So neuropathy is very common in patients with diabetes. It's affecting about 60 to 70% of them. And the most common presentation is a chronic distal sensory motor neuropathy, which affects the sensory nerves more than it affects the motor nerves, and typically presents in a glove and stocking distribution. So these patients might not actually be aware of their sensory loss, and that's why the diabetic foot checks are particularly important on an annual basis, because once they lose that sensation, their risk of diabetic ulcers significantly increases. So other ways a diabetic neuropathy might present includes an acute painful neuropathy. So this is something that typically comes on quite acutely. It's usually a diffuse pain that's worse in the feet and worse at night. It's often associated with poor glycemic control, a bit like our patient in the case study. So trying to improve glycemic control is an important part of management, and it sometimes just resolves spontaneously. Mononeuritis can affect any nerve in the body, but in patients with diabetes, most classically affects the third and sixth cranial nerves, causing an ocular palsy, or causes a carpal tunnel picture. Again, they often sort of fully resolve spontaneously. Diabetic amyotrophy is a proximal neuropathy that affects the lumbosacral plexus, and it causes weakness, wasting, and pain, mainly in the quadriceps muscles. The management involves, again, optimizing their glycemic control and then managing the neuropathic pain as we discussed in the previous slide. And then finally, autonomic dysfunction. So that's damage to the autonomic nervous system, and that can have a variety of effects. So you can see patients with postural hypertension, with bladder dysfunction, with erectile dysfunction, with diarrhea. Patients might become less aware of the symptoms of hypoglycemia because of autonomic dysfunction, and some patients may develop gastroparesis, which is delayed gastric emptying that can cause vomiting, and sometimes prokinetic agents like metoclopramide and domperidone can be useful for those patients. So that's diabetic neuropathy. And just to touch on the diabetic foot. So we mentioned that nerve damage and loss of sensation is a risk factor for developing a diabetic foot ulcer. And that's in combination with poor peripheral blood supply in the feet of diabetic patients. So during that diabetic foot examination, they're checking for neuropathy and also for evidence of ischemia. And it's actually quite a poor prognostic sign. So patients who have diabetic foot ulceration, around 50% of them will have died 5 years after developing the ulcer. And patients who require an amputation because of their diabetes, around 70% of them die within 5 years of the amputation. Another sort of well-known complication of diabetes, and you might see in the diabetic foot, is Charcot's arthropathy or Charcot's joint. And this is a complex neuropathic arthropathy that results from the loss of sensation and the subsequent repeated microtraumas to the foot. And traditionally it affects the midfoot. And that microtrauma in the presence of poor peripheral blood flow causes like a remodeling and swelling and sort of distortion of the whole joint. So I'm afraid I didn't put a picture of a Charcot's joint on this slide, but you can have a quick Google to see what they look like. A third microvascular complication of diabetes is diabetic nephropathy. So in diabetic nephropathy, you get damage to both the afferent and efferent arterioles, as well as glomerular sclerosis. And it's one of the most common causes of end-stage renal failure in the developed world. So the earliest sign of diabetic nephropathy is usually the presence of microalbuminuria, which you can pick up through albumin-creatinine ratio screening. And patients with diabetic nephropathy might also develop things like a normocytic normochromic anemia and also hypertension, which in itself will further damage the kidney. So important steps to try and reduce the risk of progression of diabetic nephropathy include strict glycemic control, managing the patient's cardiovascular risk factors, particularly hypertension, and then often patients are started on an ACE inhibitor or an angiotensin II receptor blocker, even if they don't have hypertension. And then finally, just a quick note about diabetic or microvasculature, most common cause of severe sight impairment in working age people. So the underlying pathophysiology is a thickening of the basement membrane in the capillaries and of increased permeability of the retinal arterioles. And this can result in two types of damage, an occlusion or an aneurysm formation. So in the earlier stages, on fundoscopic examination, you might find things like dot and blot hemorrhages, hard exudates, cotton wool spots, or venous loops. As it progresses in proliferative retinopathy, new blood vessels start to form on the surface of the retina in response to the hypoxia, and they can cause a vitreous hemorrhage. And then the vitreous hemorrhage and traction retinal detachment, if left untreated, can lead to permanent blindness. So management of diabetic retinopathy again involves good glycemic control, annual screening, and then in the proliferative stage, you can use laser photocoagulation to try and prevent that proliferative retinopathy from progressing on to a more permanent blindness. Okay, so that was sort of a quick run through of type 2 diabetes. Hopefully that was useful for you all. If you have any more questions, do pop them into the Q&A box, and I'll just start to have a look now at what you've got in there.
Just to quickly say, I popped the link for the feedback form in the chat, so I'd really appreciate it if everyone could fill that out. Should only take a couple of minutes, and everyone that does fill it out, if you put your name and email address down, then you get entered into a fortnightly prize draw of loads of really great prizes.
Fab. So there's a question about, with the 2 repeat tests for asymptomatic patients, how spaced out do the tests need to be? So when I was looking through all the NICE guidelines and things like that, they didn't specifically give an amount of time, or even necessarily whether it had to be 2 of the same test or 2 of a different one. So potentially you could have done a HbA1c and a fasting glucose at the same time, and if both of them are abnormal, then that's going to make your diagnosis for you. I could be wrong, but from all the reading that I've done, I don't think there is a specific amount of time you need to space the test out by. It's just having those 2 separate readings that's important. And then there's a question that says, I said HbA1c cannot be used for diagnosis in patients with anything that affects the erythrocyte lifespan. Can HbA1c be used as a target in treatment, or should another measure be used? So you would typically use another measure rather than HbA1c. And my mind's just gone blank, but there is a different type of test that you can use as a monitoring test when HbA1c isn't appropriate, and it has its own like cutoff rates and things for that. I'll try and have a quick Google for you in a minute and see if I can find it. And then there was a question, if fixed rate insulin infusion, is fixed rate infusion necessary with HHS, or is fluid resuscitation enough? So fixed rate insulin infusion is almost always necessary as far as I can tell. You do typically start with fluid resuscitation first, and there are some guidelines that say you shouldn't start the fixed rate insulin infusion until after the glucose isn't reducing anymore with just the fluid, because it can make a significant, have a significant effect on the hypoglycemia, but generally you would need to use the fixed rate infusion as well. And then I think someone's just popped one on about bolus insulin. Can you explain the main points about bolus insulin again, please? So again, I didn't cover this in a lot of detail because we could have been there all day, but basically when you start insulin replacement therapy, you're trying to replicate the normal physiological process as closely as you can. So normally beta cells reduce insulin in 2 phases. The first phase is like a rapid response to raise blood glucose levels, and so has a maximum onset within like 10 minutes. And the second phase is a more slow and sustained response that has its maximum onset within sort of 2 to 3 hours. So you might have heard of a basal bolus regime, which is basically us trying to replicate that. So you use a intermediate or long-acting insulin like Lantus or Levemir to give that sort of slow and steady long-acting insulin cover, and then the patient uses fast-acting insulin like Nova Rapid, which they take sort of 15 to 30 minutes before eating, and that gives them that sort of quick insulin response to address the raised glucose after eating. I hope that answers your question, but let me know if that didn't make things any clearer. Otherwise, I think that's all the questions in the box. So yeah,